So my name is Laura Pisaneschi. I'm the operational lead for our team. So I'm come to talk about one example of our crisis follow-up, so our A&E follow-up clinic. So this is our team. So this was taken at our away day on Saturday, actually. So it's the most recent photo of our team. It includes all of our nurses, 2 of our consultant psychiatrists, myself, our psychologist, and our nurse consultant Reggae as well. So I missed a slide there. Okay. So in terms of our team, so we are based in Tower Hamlets in Whitechapel. We're based in a major trauma centre. We're based in one of the 5 major trauma centres for London. Over the last few years, Tower Hamlets has seen a 25% increase in population. We get on average about 3,500 referrals a year in A&E. We get more referrals for the wards as well. And some of the people who come in with severe self-harm go directly to the wards or with trauma, and so don't get counted in those referrals. 70% of the referrals that we get are from Tower Hamlets, but we do get referrals from other boroughs as well and out of areas, especially in London, some of the close ones, and we get people who travel to London from other areas. In the borough, there's quite a lot of high health inequalities and social deprivation. Tower Hamlets has a lot of links to the City of London, so it has a lot of millionaire homes, and it also has some extreme social deprivation as well. So in terms of staffing, so as I said, the picture that we showed at the beginning, we have our largest workforce is the psychiatric liaison nurses. We have myself as the manager and operational lead. We also have a nurse consultant. We have consultant psychiatrists and trainees. We have a lot of consultant psychiatrists, trainees. We have psychologists. We have an OT, and we have admin support as well. So in terms of the clinic, so we've been running the clinic for the last few years. We run it every Tuesday. It is run predominantly by our Band 7 psychiatric liaison nurses. At times, if there are issues or staffing problems, then either myself or Reggae, who's a nurse consultant, or one of our other senior nurses will run it. The idea is that somebody has a maximum of 3 contacts. So we don't run it as a continuous follow-up, but we will hold people and we will do follow-up for 3 times. So normally we'll book people into this clinic when they attend. If we decide that they need to have follow-up, we will book them in, and it could be that they, at that appointment that we have in the clinic, we will decide that they need a future one, and then we'll book them up to 3. We are also flexible, so sometimes, although we say 3, we have done 4 sessions for people as well, and I think the maximum we ever did really was 5. And sometimes we'll do these outside of these Tuesday slots as well, depending on what's going on for people. So in terms of looking at the reasons for follow-up, so we did an audit across a year and looking at the different quarters. The green section is the risk review. So this was the main reason for follow-up, so reviewing risk. We also found that people were awaiting follow-up. So the light blue shows you, the darker blue shows you awaiting follow-up for other teams. Drugs and alcohol being one. Reviewing a mental state, deterioration in mental state potentially. One person didn't have a GP. It has got a lot easier now to register people with GPs, but sometimes that could be a reason for follow-up. And that if we were linking them into other services, so crisis intervention services, that we might need to follow them up that way to check on them. And often what we find is a social input as well, so needing support. And it might be that they don't have anyone else checking on them, that they don't meet the criteria for secondary services, or they're waiting for secondary services. So our follow-up is in that way to check in on things. And we have had follow-ups with people where we've actually then brought them back into hospital, or we've arranged appointments with them again and linked them up to other teams. Pre-COVID, our appointments were always face-to-face. Now we do a combination of face-to-face and telephone appointments. So when we looked at an audit of the clinic, so this was in 2019, we carried out an audit of the clinic, and we were looking to see whether providing follow-up and interventions actually made any reduction. And we found that 73% of people who attended clinic weren't re-attending A&E 6 months post-clinic. We actually found that before COVID, as I said, we were doing a face-to-face clinic, unless people specifically asked for telephone appointments. And we found then we had quite a higher DNA rate. But actually, since COVID, we started doing a phone contact and phone clinics, although we will see people face-to-face if they want to. And we found that this has actually reduced the DNA rate. So some people really prefer phone contacts. The benefit, obviously, with phone contacts is that if we can't get hold of somebody, then we will follow them up. So we'll try and call them. We'll call them again later in the day. We'll text them, and then we'll call them again in a few times, and we'll link them back up so that often they can call us or link into us. The audit and the evidence that we've been looking at and kind of doing it ourselves has found that it's a very useful way to review risk and check in whether that safety plan that somebody made, especially when we're thinking about follow-up for self-harm, that safety plan that could have been made at 2 o'clock in the morning in A&E, we're checking, is that actually still valid? Do they need anything else? Now it's the light of the data, so to say. So pros and cons, so we'd say it definitely is it's reduced returns to A&E. We do get a lot of positive feedback. A lot of the service users really like the clinic and like having that kind of touching base. For our clinicians who are assessing people, they really like the clinic as well, in that sense that when they're not sure what to do or who's going to pick them up, then having that clinic to link someone into can really help. We often find as well that it helps to kind of communicate that we care. And although that sounds really cliche, it's something that's really important for us, that actually we're not just because you're coming into A&E, we're not forgetting. And even if other services aren't helping, we want to help, and we want to try and link in and see what else could actually help. And for some people, that might have been that we've linked someone up and we've been able to then get them support with their housing, or we've been able to get links into their community mental health team, or as we now have them as neighbourhood teams. However, this can have a con. So what we found recently is, probably because the pressures everybody is under, that often the community teams will think that because we're picking somebody up and following them up, that they don't need to pick them up as quickly, and that this can be a delay for some people. So we've actually looked through some of those notes and seen that, well, they're being seen by the follow-up clinic. Actually, we don't need to. But our idea initially when we set up the clinic was it was never for people who were going to be referred to secondary services. However, that's the model that we've adapted to, because actually we've realised that there is a gap, and that the people that we're seeing do need support and do need help. I'd say another con is probably just the staffing as well. So we try really hard, as I mentioned earlier, to make sure that it's always covered by our A&E team. But in liaison services, you never know what that day is going to be like. So sometimes it is covered by the rest of us. I think doing that phone has made it a lot easier, because we can all take it in turns and arrange those phone appointments as well to suit people. So kind of thinking through about what our plan is for next. So our plan is to re-audit. So our audit was done just before COVID, so we'd like to do that again. We'd also like to get more feedback from people who use the clinic. We are, like a lot of liaison teams, we do struggle with patient feedback. We have started using text message, but it's hard to differentiate between clinic and other appointments. So we would like to ask for direct patient feedback for the people who are using the clinic. And one thing we'd like to look at is a social prescriber input. So what we have noticed is that there was a lot of social stressors that's coming through, and a lot of other things that medication or therapies wouldn't necessarily help with. So we would really like to have a look at social prescriber input and see how maybe we could do joint work together. One thing we tried in the past, just before COVID, was to have like a mind worker with us at the same time. Then because of COVID, it was made very difficult, but it's something that we would like to think about again, to have a look at different ways of supporting people. And that's all of my slides. And